Thank you for this opportunity. Some of the speakers of the previous abstracts can also join in if they are available. And I do not have a conflict to disclose. And this is the first line treatment landscape in advanced UTC who was cisplatin eligible. So cisplatin was 1978. Then in 1992, MVAC happened. MVAC versus cisplatin is it is a superiority study. The design was superiority. The numbers was close to 270 numbers. By doing MVAC, the response rates have increased, the PFS had improved, the overall survival had also improved. This is possibly one of the best study which has shown this greater result, even though the bar was very low set, but that is how it was. Now in 2000, gemcitabine was approved in other cancers. So this regimen, gemcitabine and cisplatin, this is not the same gemcitabine cisplatin which is currently used or currently discussed in the previous Nivo gemcis, this thing. This gemcitabine cisplatin was given over 4 weeks, and it was compared with MVAC, which was conventional MVAC, that was also 4 weeks. So this study, as you could see, those numbers that are in red, they are statistically significant. Those who are not red, they are non-significant. This study was, it was planned to prove a superiority of GemCis over MVAC, but this was a clearly negative study. Now, oncologists are very fashionable. They interpret studies as per their own this thing. Even though it was a negative study, gemcitabine cisplatin, it became a standard of care because it was less toxic. Near about that time, somewhere around 2001, this DD-MVAC was proposed. This was a study which was, I mean, the numbers were not great. This was a superiority design study. It was only 250 patients. The response rates have improved. So is the progression-free survival. But the numbers were not great to produce an overall survival benefit, and the primary endpoint was PFS, not OS. Now, this is the study which was been presented by the previous speaker. Now, this is GC3, gemcitabine cisplatin, which was given over 3 weeks. Even though it is the standard of care, it is considered as a standard of care, but there was no study to show superiority of GC given over 3 weeks over GC given over 4 weeks. And it was compared with addition of nivolumab. Now, even in this phase 3 study, avelumab was not proposed to be included as maintenance. That is one deficiency of this study. But when you look into the incidence, I mean, the proportion of patients that have received an immunotherapy in the control arm, it was only 40%. It is because many of these patients, they progress following these treatments. Many would not be eligible to receive immunotherapy. That could be one cause, but the other causes are not clearly explained. Now, this is the big step in urothelial cancer. I think this drug, which is enfortumab vedotin, which is a glorified vinblastine, when it was given with immunotherapy, it has toppled gemcitabine cisplatin. This study also suffered from the same thing, that in the control arm, avelumab was not used. But the same, I mean, when you look into how many have got immunotherapy in the control arm, it was somewhere around 40%. So the best option to treat patients who have got advanced UTC, because these are not carcinoma ovaries, these are intermediate platinum sensitive. Even while treatment, 10 to 15% of PS 0 to 1, because in clinical trial setting, when you see, close to 10 to 15% of patients will progress while on GemCis. With addition of Nivo, it will be less than 10%. So it is important what we use at the first line. So this is a question to everyone. Let's say in patients who are cisplatin eligible, what are the chemo options that you provide to your patient? Do you uniformly give GemCis for everyone, or you use gemcitabine cisplatin in many and DD-MVAC in few? I will start with And you use the gemcitabine cisplatin at a 3-weekly protocol, or you use split dose? Okay. And you give cisplatin as a single day on day 2? Okay. So no change in protocol. Okay. Dr. Suratika? Okay. So normally the split dose of GEM-CIS is you give GEM and CIS on day 1 and GEM and CIS on day 8, and then you wait for 2 weeks. That is the usual. Yeah. Okay. So you give a 2-weekly GEM-CIS in a way. Perfect. Rohit?
So practically, in the package setting, game does that for all. In games, right? Game does something for one. Okay, it's also. If there is a borderline of day 1 day.
Yeah. And what is your opinion?
Please, my co-panelists. So majority times in my practice also, those patients who are cisplatin allergy, I'll be dividing the dose of cisplatin. Gemcitabine is anyway day 1, day 8 we are giving. Cisplatin also day 1 and day 8, and then after 2 weeks back again. Majority times, yes.
So this was an interesting aspect. Now, what is your bias? And there is a study that I have shown that MVAC versus dose-dense MVAC. Now, could you speculate which arm would have got all the cisplatinins between DD MVAC and conventional MVAC? What is your bias? Let's start with you.
So we have tried using DDMVAC only in the fit patients, especially young and fit patients who can withstand the side effects of this. We know that it's called hematological toxicity. Majority patients, when we have burned our hand in our practice, after first dose or even second dose, they'll end up in ICU. We don't want to do that. Ultimate aim in advanced setting is that we have to keep these patients as good as possible for as long as possible with limitation of science. We know that urothelial cancer per se, it's a deadly disease. So we have to use the treatment in a proper way depending on the merit of the patient. So majority of my patients.
This had been a major bias. When you look into the study proper, DD MVAC was more deliverable. So when you are giving DD MVAC, when you are giving that will be 280 milligram per meter square cisplatin, it is deliverable within an 8 weeks. But when you prolong it to somewhere around 4 weeks, only 65 to 70% could get that desirable cisplatin dose. So even though we practice GEM-CIS, we are okay with GEM-CIS, but DD MVAC remains an option in patients who are ultra fit. And this cisplatin could well be deliverable to a larger extent. There are other studies, not in a locally advanced or metastatic setting, where DD MVAC was found to be better than GEM-CIS. So it is an effective regimen. It is just that we do not have the best trial which is conducted. And with now availability of all these things, basically nivolumab and enfortumab vedotin, I think the whole paradigm would now change. So now let's come to this era where now there are so many first-line options like EVPIM and NivoGC. I would also include here the Javelin strategy. GC followed by, we are restricting our discussion to only cisplatin eligible patients. So how do you choose, let's say everything is available, which one would you choose, Rohit?
If everything is available, probably the best treatment.
Okay.
And I will choose.
Okay. And if let's
So,
say, yes, yes. So if EV, because EV is still not available in our country, what is the next approach that you would suggest?
So between NeoGC and GC followed by available maintenance. In the NeoGC trial, the CR rates was around 21%. The duration of CR was around 2 years in patients who were CR. As compared to that, available maintenance not that much. Responsibility was probably, but how much is the concurrent administration of Nevo actually? Response rates are higher. But NeoGC probably I will be choosing NeoGC over GC followed by AIIMS.
Anyone has another thought apart from what Rohit said? Dr. Majumdar? Okay. Right. Mhm. Yes. Perfect. I completely concur. And what about you? Okay. Do you have the same feeling?
So few things I want to consider is, first of all, whether the patient is platinum eligible or not, right?
So this is cisplatin
This is
eligible.
also the same patient we are discussing. So in this patient, obviously accessibility an issue as of now. So to our disposal right now, nivolumab and GC is a viable option which can be delivered from tomorrow, today only. There are few things I want to highlight here is that this combination will work in those patients who are having a non-visceral involvement, especially the nodal involvement is there, which this drug is going to work even better. Second thing is that ERCC mutation. If you are having ERCC mutation, these patients respond very well. The biomarker which you mentioned. So ERCC this responds very well to the platinum drug. So we
Perfect.
should not use PV pembro. We don't want to deny the potential benefit of platinum in those patients who are having ERCC mutation upfront. So if those patients who are having ERCC mutation, even when I know that EV pembro is having a 31% overall survival, this drug may not work upfront. Right? Theoretically, we can discuss in the first slide we mentioned all this, but there are some biomarkers which can select out in this patient in which
Excellent answer. Excellent answer. So possibly you have answered that thing, that is low risk and high risk. And to re-stress the fact that Rohit told about the complete remissions with NevoGC, these complete remissions have only happened in patients those who have got nodal metastasis. So patients who have got nodal mets, possibly NevoGC is a better option than EVPEM because the duration of response could be as great. And as some of the previous speakers have suggested, enfortumab vedotin given over a very long time, especially in this sort of patients who are curable in a way, then it could be very toxic. NevoGC is pretty okay. And the duration of remissions, CRs are more in those who have lymph node mets. So you could use NevoGC for a very long time in these cases. And high risk are the patients who have got other organ mets, like say liver mets or some other organ mets, where EVPEM could be scoring better than NevoGC. Biomarkers, the ERCC2 thing, it is an excellent proposition. This biomarker was actually derived from the DDM-VAC study, okay? But it was never, replicated in other studies. So I agree, ERCC2 could be a hint, but it requires to be same. And ERCC2 is not commonly available. It is only available as a research immunochemistry, maybe restricted to few institutes. But I completely agree there requires better stratification with respect to the type of meds or these biomarkers. Yeah. Yeah. So biologically, as of today, the nodal meds, they are the best responsive to immunotherapies. Okay, I completely agree. We require more thoughts on it. But yes, those patients who have got only nodal metastasis, biologically, otherwise, had it been a bad biology, it would have reflected in other areas. No, I agree to that completely, because patients who have locally advanced or metastatic, only lymph node mets will be a smaller fraction. And this is well represented in that NevoGC study. So it could be a better proposition, but I completely agree because enfortumab vedotin, the microtubule inhibitor here given as an ADC, it is uncomparable as of today. We will discuss more about it in the forthcoming slides. Yeah. Yeah.
For limited duration. Over a period of time, we will continue.
It is.
Advantage.
I have limited experience, but it is a terrible drug.
Obviously, side effects are there.
EV is a terrible drug. You know, the hyperglycemias, the neuropathies, they are terrible. Yeah. Because even though it is an ADC, it means there is a lot of microtubule inhibition which is happening within the circulation. So there could be some modified, better versions of this EV, which is possibly in future. So this is, yes.
Basically, enfortumab vedotin, the side effects in the relapse refractory setting, so second line setting, who are exposed to a lot of, and we see the 3 weekly regimen. I think we were much more than what is in the first line setting, day 1.
Okay.
Talks,
Because they have closed platinum,
exactly.
another neurotoxic drug. So. I personally feel it requires more dose optimization because with pembrolizumab, they are synergistic ways of delivering treatment. So more optimization could be there. So this is an interesting study. This was published in Clinical Care Research last year. It shows that the Nectin-4 expression, it could be pretty nicely seen in patients who have got primary tumor. I mean, those who have got localized disease. But when it is metastatic, the expression rates, it decreases, as you could see in the immunochemistry, and this is from the ESCO. The same tumor from the primary and metastatic, there could be discordance, and the Nectin-4 expression could actually be declining. So in future, you would be getting patients, maybe sampling the metastatic sites, see how the Nectin-4 is, and then decide what should you give in future. And this is just, I mean, those patients who have got Nectin-4 less, their outcome is not so great in EV, and those who have got Nectin-4 high, they are better. So this is for cisplatin eligible. Now let's discuss about carbo eligible, those who have got GFR more than 30 and less than 60. In 1992, it was Emcavi, which was carboplatin and vinblastine. And in 2012, it is gemcitabine and carboplatin. And gemcitabine carboplatin, it is not better, but yeah, it is more feasible. I don't know why people hate methotrexate so much. So this is the gem carbo versus EV pembro. And these response rates are not from the gem carbo group. This is from the whole group. But the PFS, if you see with gem carbo, it is 6.5, and with EV pembro, it is 14.6. So when you are using EV pembro, this cisplatin eligibility, non-eligibility doesn't make any sense. Both are doing equally good. So definitely, this is the thing to look for in the future. Now, let's say in patients who are cis ineligible but carboplatin eligible, now you have got data about GemCis and Nivo. Will you do the same thing with gem carbo? Will you add nivolumab to gem carbo?
There's no concrete literature.
Yeah.
It's only versus platinum eligible patient.
Yes.
But if at all any trial comes in future, then we will be optimistic.
So
Yes.
I have given the pembro plus trial included both statin and carbo. They are smart enough to include these data.
Yes.
So I think that also the subset who is statin, it seems to benefit to the addition of immunotherapy. I don't think we should add immunotherapy.
Right. Any other thoughts? Perfect. Okay.
So I think the way would be maintenance.
I agree because that has got some robust data. Yeah. And do you have an answer?
Yeah, I think it is really good.
So this is what I was trying to come around. This is AIIMS study. Now, as some of us have actually told that these patients are sicker, And what do you feel in patients who are, let's say, cisplatin eligible, carboplatin, can it produce a similar benefit or near similar benefit as cisplatin? What is everyone's answer? Okay. Okay. So this trial, what it did is, because they were using IO with chemo option, so they have put an investigator choice. So the investigator has the option to discuss with the patient. And most of the investigators, they feel that carboplatin could be okay when you're adding IO. And this study was actually negative just because of this feeling of oncologists. So there was a platinum effect. So IO was producing a benefit when you are using cisplatin. IO was not producing a benefit when you're using carboplatin. And this is the basic reason for this, because cisplatin, possibly it is more immunomodulatory. Because even though when you look at the bladder tumors, they are immunosensitive, but the microenvironment which is surrounding the tumors, they are immunosuppressive. So when you are giving a chemotherapy, it resets the thing. It will reset the whole process when the tumors are responding. The more chance to respond will be with GemCis than GemCarbo. And this was a very really well-conducted study. As you could see, these are complicated pictures, but this is in patients who have received GemCis. With GemCis, there is some inflammatory response that is happening. When you are, this is GemCarbo, those inflammatory responses are less. When you're adding an IO, which is Atezo in this case, with 2 GemCis, you could see the difference. There is more redness. It means it is more inflammatory. So these patients would be responding to IO more. And when you do the same thing with GemCarbo, you see the redness is a lot lesser. It is happening, but it is a lot lesser. So as of today, if you're adding, let's say an IO to GemCarbo, this thing, either you have to blow up the number. There could be very minuscule difference. Either you have to blow up the number or follow a javelin strategy. So this is another thing, basically. So we have left around MVAC, and EV is actually revenge of MVAC over GC. Okay. So you have only taken one component of MVAC, which is vinblastine, made it to an ADC, and now it is working the best. And this could be one of the reasons that vinblastine possibly resets the tumor-associated macrophages. And this could be with vinblastine, the IOs might actually get better. So don't leave your DD-MVACs yet. In an LMIC setting when you are not using a lot of IOs, your DD-MVAC can do a thing when you add a low dose IO sort of thing. Yeah, so I'll skip it. This is NCC and I'll skip. So second line. So in second line patients, what is your preferred option? We'll start with, yeah. Okay. Right. So this is the study, Keynote 045, where pembrolizumab was found to be better. But this is also a biased patient, because if it is 100% at first line, it is 50% at the second line, 50% that are eligible. If you take 0 to 1, it will be somewhere around 30 to 40%. So these are biased results, but yes, when you wait for the patient to relapse and don't do javelin, then there could be some this thing. So what is third line then? What are your options on third line? One, Dr. Majumdar has actually discussed. Yeah. So enfortumab vedotin is also a third line option post your chemotherapies and IO this thing. So it is also found to produce an overall survival benefit. This is one of the abstract which was not presented by the previous speakers, is the outcome of patients when you are giving enfortumab vedotin, those who have received avelumab as a maintenance. So this was an oral presentation, and it was found that patients who have received prior avelumab, enfortumab retains its efficacy. So it is an option as third line. So this is the erdafitinib thing, and I won't go into detail. It had improved the responses, the PFS, as well as overall survival in patients who are FGFR alteration. Now, the technical point in bladder cancer is there is no FGFR2 alteration. It is mostly FGFR3. And this is another thing, because now we got more than an option as second or third line. And let's say in an FGFR mutated patient, which one would you use as the first line, as the first agent followed by the other agent. May I have answers? Because erdafitinib, it is shown to have increasing the Nectin-4 expression in urothelial cancer patients. So technically, possibly from the basic thing, it was found that it was thought that erdafitinib should be used first, followed by enfortumab. So what are your thoughts?
Followed by 19 to 21 was the overall survival. For the monotherapy, it was around 12 months.
Yes.
So I think the sequencing is okay.
The sequencing is okay. The only problem was in the overall response to EV. So when you use erdafitinib first, followed by EV, the overall response rates are lesser, 32%. But when you use enfortumab vedotin upfront, it is 67%. So that is the only anomaly here. So it requires to be seen in a prospective manner. But the overall survival and the PFS, they appears okay. But yes, as of, if you look into this data, possibly EV can be used first, followed by erdafitinib. So to conclude, the first line for patients who are cisplatin eligible, it is EVPEM, it is Nivo GC. I have kept a comma. It could be GC or DDMVAC followed by avelumab maintenance. For patients who are carbo eligible and cisplatin non-eligible, it is EVPEM will be the best. Nothing can topple it. Then it could be gemcitabine carboplatin followed by avelumab. For subsequent lines, EV has got an edge, or maybe the other one, sacituzumab or erdafitinib. Sequence, possibly EV followed by ERDAF is a better sequence. And biomarkers, as we were discussing, maybe Nectin-4 can be explored in future to select out patients who get enfortumab vedotin. I didn't discuss the abstract, which was HER2 and PDL1, willfully because it was crossing this. So I would thank my panels. I'll be happy to answer any question or clarification if you have.
SG, sir, we should do the top 2 expression by IHC.
Yes.
Those patients who are positive, then I will be switching over to SC. We are having 2 patients who have done very well on SG also.
Absolutely.
Trial going on right now. That trial, it is EV plus SG. So it is my Goveting and also combined. We will be like optimistic how the trial will turn out.
Yes.
That also is on the way.
Yes. So possibly in future, you would be treating patients with respect to these biomarkers. Those who are expressing, they will get it. Those who are not, then they get the other options. Possibly, yeah. So thank you very much.